It looks like we're ready to go. Good morning and good noon for those on the East Coast. Um, just want to do a quick check-in before I orient us to this weekend's course. Um, I think you can see me and hear me, and let's make just double sure. Great, thank you, Eddie. Um, and yes, great, Maribel, Amber, excellent, wonderful. Good group today. Excellent. Okay. So, um, most, if not all of you, have met me before, virtually. Um, and thank you, Jason. And I'm Dr. Tom Brady. I'm a board certified psychiatrist. And I taught the course in child and adolescent psychopharmacology last November. And now I'm teaching this weekend on ethics and legal and interpersonal issues related to psychopharmacology. And as I understand it, this is the tail end of your 3-year master's program in clinical psychopharmacology. And we find ourselves at a particularly bizarre time in our lives with this coronavirus pandemic. And before we jump into the subject matter at hand, I would like to just open up for anybody who'd like to share anything related to what they or their loved ones, workmates, etc., are dealing with and going through with this coronavirus pandemic. Never in our lifetime have we experienced this. Hopefully, never again. And I think it's important to mark it for its importance and bizarreness. And also, you folks all know each other virtually. So you're one step ahead of everybody else in terms of virtual social connection. And I'd like to take just a few minutes to check in about this. Maybe I'll start if you don't mind. So I'm going to turn 68 this year and have some underlying health issues, and I'm hiding out at home in Palm Springs, California. I have a husband we've met in college, so we've been together 45 years this summer, who has pulmonary fibrosis, hypertension, and diabetes. He's one of the highest candidates for getting coronavirus. And so he's home all the time, except to go out on socially isolated bike rides. And I'm the one that goes out to the store once a week, and it's all very bizarre. And we're just starting to wear face masks in stores. On my dog walk this morning with my 2 Labrador retrievers, probably half of the people on dog walks are now wearing face masks. So things are evolving daily, and everything's safe, but it's all rather odd and surreal. So with that little intro, who wants to jump in and say something or write something on the chat room? Go ahead, please.
Hey, this is Eddie. Can you hear me?
Yes, Eddie, sure. Thank
Okay.
you.
I'm relatively kind of safe from the high risk category. I'm 43, prior military, pretty decent shape. My family is pretty young and healthy. I'm more concerned about my sisters who are about 15 to 18 years older than me, so they're more in the high risk category: smoke, COPD, heart stents.
Right.
I work at the VA, and I'm on the PTSD clinical team. So we've been tasked to be the trauma-informed providers to provide support for our medical doctors who are expecting a surge. So we're actually wrapping our heads around how to help them out with support when they have to make difficult decisions about, for example, who may or who may not get a respirator, dealing with a lot of the upcoming anticipated kind of death that they'll probably be seeing. We're getting kind of pulled in for additional support. So,
And Eddie, where in the country are you?
I'm in Colorado.
Colorado. Okay.
Yeah.
Wow, you're right in the thick of it then, in terms of your work at the VA. Okay, very good. Thank you, Eddie. Others, Heather, I've been working side by side with physicians that treat COVID. Our hospitals are full of it. It's a lot of increased anxiety, depression, needing psychotherapy during this time, including the physicians and nurses. Amen. Yeah, the frontline people. And Rebecca, I've had to learn about using telemental health, and I have a few patients who want to use it. I'm surprised at how few people are reaching out for therapy. I think everybody is shell-shocked. When I talk to people and friends and acquaintances, everybody's just sort of circling and figuring out what the hell's going on here. Others who'd like to join in on this brief discussion. From Monica, geriatric primary care, hardest decision telling people not to go to the ER. Exactly. Because if you go to an ER, you might get sick, right? And you want to avoid the hospital if you can, just to free them up, but also not get infected yourself or bring it home to somebody. Jason, mid-30s, adult male, family history of primary hypertension. So you're at some risk. So you're in Fresno, dead center of the state, still go to work every day. Wow, okay. And Kirsten, having more patients wanting help, asking for therapy. I've had patients ranging from blasé about it to very concerned, point of putting themselves and family in danger. Yeah. That's been the big concern, right? We can't flatten out this curve in America because people aren't taking it seriously enough for social isolation, home isolation. Jason, we've increased the number of telehealth sessions, although I still primarily see patients in person, become even busier. And Najib, even healthy people can get sick. I'm not sure what the therapy when therapy will be available. And Najib, allergies and mild asthma. Okay. And Joy, your tenant's an ER nurse, basically exposed every day. But so busy switching over my company to virtual, I'm busy and exhausted every day. A good point, Joy, that you raise of how important it is to maintain as much as possible life balance, sleep, eating properly, etc., so that you'll keep your wits about you. I've offered to help from Rebecca in New York and Ohio, no requests yet. And I'm worried about substance abuse, detox, domestic violence. Yep, that's a big one rearing its head. Suicidal ideation not being addressed due to isolation. I love working from home, which is a plus. Exactly. So, okay. Anybody else who'd like to chime in, either chat line or verbally, video, etc. Well, let's, this is good, and thank you. And let's keep up the hard work. I think this is going to go on for months and months, and maybe even longer. So we just don't know. We just don't know. That's the big scary thing. We just don't know. And try to keep your, yeah, 2020 is canceled, Janelle. Boy, isn't that the truth? First time I've heard that so clearly put. 2020 is canceled. So, except for this course, right? And your curriculum. So we're going to get through this and manage it. So it's Costco toilet paper and cases of water, and the ones we teach, right? And our patients and our clients and our loved ones. Can't tell you how many conversations I've had um, having social connections with friends, but in the driveway, standing 10 or 15 feet apart, um, and at the door, and wiping down packages with bleach wipes and stuff like that, just for an abundance of caution. And Rebecca, I'm glad you honed in on this. Found taking the last exam difficult with all the distractions. And this course is going to be challenging, not because it's so incredibly complex and difficult, but just because it's kind of dense and there's a lot of material, and uh, and there's a lot of stuff to get through. I want to assure you, and we'll talk about this in just a few moments. And yes, I was able to get bleach wipes. Actually, I got them 6 months ago, before I even knew that I needed them. Yeah, and you can make your own hand sanitizer, etc., using alcohol. I remember in the old days, from a trip from Italy, I brought home some alcohol puro, which is 180 proof or 90% alcohol. And unfortunately, it got used up over the years, but that would have been a perfect medium for making hand sanitizer, along with some aloe vera. And what do they say? Tea tree oil. All right, let's shift gears and start with the course. And first, I'm going to orient you to the course in general, and then we'll go into some specifics of the table of contents. So this is a 12-hour course, 6 hours today, Saturday, 6 hours tomorrow, Sunday, on the pharmacotherapeutics, legal and ethical, or ethics and legal issues, and interpersonal issues. It's a bit of a grab bag course in the sense that I'm going to get across to you through the lecture material, the PowerPoint slides, and the references that hopefully you all got through Moodle, an extensive and a bit controversial volume of references. I'll talk about that in a moment. But I wanted you to have everything that I had and then some to have as references for yourself for the future. That doesn't mean necessarily that you know everything at all in the references, but just that you know what's there and what's available, and we've at least gone through the table of contents, so you know what's available to you. The course, the mechanics of the course are that we'll have 6 hours of lectures today. Actually, there'll be 50-minute hours, because what I'd like to do is take a break at approximately 10 minutes before the hour and start up again at the top of the hour. So we'll have a 10-minute break once an hour for bathroom or etc. Pet your dogs and cats, kiss your loved ones, check the mail. And then we'll have an hour lunch break at 12 noon Pacific time, 3 p.m. Eastern time, starting up again at 1 p.m. Pacific time, 4 p.m. Eastern time. In terms of the flow of the course, my preference is to have you all on mute and use the chat room when you have an issue, a concern, a correction. I'm not always right. I make mistakes, hopefully very few, but it is known to happen. And I'd like to be corrected in real time or you might have a comment. You might have a an example, a case example to share that would be helpful for the rest of the students, and I want to encourage that. If you really want to unmute and go on, let's try it. Let's give it a try. I just don't want it to be too disruptive to the flow of things, but in the past we've done it and gotten away with it fine. So let's be informal about this if we can. Okay. You probably want to hear about the exam and the grade, and let's cut to the chase and get to that. It's on the details are on the second page of the syllabus that was sent to you. And if you'll follow along with me, letter E, description of the course requirements and the assessment methods. So your final grade will be determined by 3 factors. One is a final exam of 25 questions, multiple choice, true or false, and that will represent 60%, 60% of the grade for the course, the weekend course. In addition, you will be sent a clinical article. It's a review article, frankly, from a presentation by a very well-known forensic psychiatrist, Thomas Gutiel, who was one of my mentors and teachers when I became board certified in forensic psychiatry, which is the interface of mental health and the legal system. And you'll have a 2-page paper to read, and then you'll be asked 3 multiple choice questions, and your answers to those questions will represent 20% of the grade, 20% of the grade. Finally, you will also be sent a half-page clinical vignette of a patient and his situation. And you will be asked to write an essay of less than 300 words, which means less than a page, that demonstrates that you understand what was going on with this patient client and the issues at hand related to legal and ethical issues in psychopharmacology. And there are even some prompting. So someone's saying, "What slide are you reading from?" I'm not reading from any slide. I'm just giving you the orientation. So this is just verbal at this point. We haven't gotten into the slides yet, the PowerPoint presentation. The essay that you'll write after the course is over and turned in to be graded will represent also 20% of the grade. So here we have 60% is the 25 question post-test, 20% for the article review that you will read and answer 3 questions related to, and 20% for the less than 300 word essay. I have to tell you folks, I've been teaching this course and revising it every year for the past 20, maybe 21 years, since 1999 or year 2000. I can't quite remember. I've never failed anybody for this course. You have to get a 70% or above in order to pass this test, pass this course. I will tell you that ever since I put in the essay portion, the 20%, I've had 1 or 2 students each year do a substandard job on it, and I've refused to accept their work. I sent it back to them and asked them to redo it, and they redid it and passed. My only supposition of why they did a crummy job to begin with is that they just whipped through it way too quickly and too superficially. It does require reading. It requires some thought and putting thought to paper. It's not rocket surgery. Everything in the final exam I have covered in the course actually several times over. And if you're halfway listening and paying attention during the weekend, you're going to be fine. None of the reference material is on the exam. You could ignore the 300-page plus reference material and do fine passing this course. When is this all due? Aidan and I have talked this over, and you have 2 weeks after the end of the course to do the 300 lesson, the essay, the post-test, and the final review paper, and 3 questions related. I know that everything's going on, coronavirus being prominent. If you can't do it, don't sweat it. We'll make exceptions. I do know you have a lot of tasks going on, and there's just a lot of tension and pressure. But I hope I'm reassuring you when I say that no one's ever failed my course. It's not meant to grab you. It's not meant to fail you. It's not meant to punish you. It's meant to help you learn this material. Okay. I hope you believe me in that. It's really true. All right. I'd like to have you just look at, if you have it in your, you should have it in the Moodle stuff that Aidan, the TA, sent to you, the course curriculum, etc. The syllabus is actually a 5-page syllabus. So we just went through the exam and the grades, etc. We'll go through the PowerPoint slides in a quick outline. You will see, starting on page 2, all of the reference material that goes on for several pages, and it's really extensive. And we're going to go into some of this in the midst of the course. My idea for the reference material is that this is something that you would have in your computer, or God forbid you'd print it out and have it in a binder like I do. But then I teach the course and revise this all the time, update it with new articles, etc. Didn't get a syllabus either, Kirsten. Hey, Aidan, can you double check that and make sure that
I am uploading it right now.
Excellent, thank you. Okay, that people get the syllabus. Great, okay, we got that figured out. Thanks for the feedback. And take a look at that during the break or whatever. I've pretty much covered it. Yeah, apparently you didn't get the syllabus, and now Aidan's sending it to you. All right. So I'm going to shift gears now, and we're going to go to the PowerPoint and start the formal presentation. There we go. One thing I want to do, I want to, there it is. Okay. I lost when I put up the PowerPoint. I'm a bit techno challenged, folks, and I can do this, but it's not intuitive. So I'm going to put my chat room window at the bottom right of my screen so that it doesn't interfere with the slides, but I can still see what you guys are thinking and talking about and worried about or upset about if that's the case. So you can see the title slide, right? And let's go from there. There we go. You can see my background. I've been doing this kind of work for the past 35 plus years. And actually, I decided to go to medical school when I was a student at Berkeley, but I'd almost finished my psychology degree. I had always intended to become a clinical psychologist, but frankly wanted to go to medical school instead because the thought of writing a book-length dissertation just felt a little overwhelming. So instead went to medical school. I had an inclination for mental health and psychiatry from the earliest of age. I think I talked about this in the child and adolescent course. The family joke is that I've been a psychiatrist since the age of 10 because it was that year that my 12-year-old brother, 2 years older, had his first psychotic break of serious mental illness that at the time was diagnosed as paranoid schizophrenia and later refined to bipolar disorder and later evolved into schizoaffective disorder. And my dear sweet brother Bob committed suicide at age 52, and we were all kind of shocked that he made it as long as he did, because he had a very troubled life of 40 plus years in and out of 40 years in and out of psychiatric hospitals and jail with this mental illness. Heart of gold underneath his psychosis. In mid-career, I decided to get an MBA, did that on the weekend, like you guys are doing for your master's program. Actually, it had a similar format. It was every other weekend, all day Saturday and half day Friday for 3 courses, a semester for 3, actually it was 2 years. And I was just thinking about that time. That was, it was at the time of 9/11. So September 11th, 2001, I was up most of the night writing a paper for one of my MBA courses and had the news on in the background on the TV, CNN, and heard about the Twin Towers being bombed in Manhattan. And while I was in the midst of writing this paper in the middle at 5 a.m. or 4 a.m., I guess it was, yeah, it was after 5 a.m. because it happened. Yeah, it was 8 to 9 a.m. in New York when it happened. So shades of deja vu with the coronavirus and you guys in your course. All right. And now I'm a behavioral health consultant. Last month before, actually, yeah, in February before coronavirus really hit in terms of isolation, home isolation, etc., I was in Los Angeles for half a week consulting with an adolescent treatment program on best practices and how to do their best job. It was a lot of fun, and I enjoy doing that. I no longer see private patients, however. Had an extensive experience as a medical director, both in hospitals and managed care, and feel blessed by all of these experiences. Maybe it's one of the things I want to get across to you in terms of your career, to be curious, to explore new territory. The fact that you're in this master's program in clinical psychopharmacology tells me that you're already there, and to expand your horizons. I have found in my 35-year career that every 5 to 7 years, I find myself getting a little itchy or bored and wanting to learn new things and do new things. And that's why I am quadruple board certified and also have an MBA. I'm a perpetual student and learner. I'm curious about everything and everybody. Having a conversation with a checker in at Vaughn's, the grocery store, just what is today, Saturday, on Tuesday, and she had her mask on, and we were chatting, and she was very friendly, and everything was super slow, 6 feet away, etc. And she sort of psyched out my cart and said, "Oh, you don't shop very much, but I see you. You probably won't be back for a month. All the dog treats and stuff like that." And I said, "You're kind of like us. You must figure out people's lives a bit by your what they have in their carts." And she smiled and said, "Yeah, I can't help myself." And I said, "Well, I'm a semi-retired psychiatrist, and I think I do the same thing." And she said, "Well, you're one of these people, I think, that when you walk into a room, you sort of size up who sits where and who's talking to who, and you have it on many different levels." And I said, "Yeah, I guess that's true. I hadn't thought about that. It's all interesting, isn't it?" And so we bonded over that. It was kind of cool as we got through this process with coronavirus precautions. All right. We're shifting slides. Can you all see slide 4? That's what I'm on. Hope you can see that. We're now on the educational objectives. When you finish this course, my hope is that you will be able to identify the laws, ethics, and regulations related to prescribing mental health medications. That you'll be able to identify relevant practice guidelines and standards of care. By the way, half of the reference material are practice guidelines for you to refer to later. To identify issues involved in collaboration and consultation with other healthcare providers, a critically important avenue of who owns the patient, who's in charge, who's the leader, how to be part of the team in a collegial, respectful manner. We're going to cover patients' rights and consent for medication. Not all patients want to take medications that are offered to them. How do you deal with that? What does the court say about that specifically? We're going to talk about the pharmaceutical companies, their largesse, their marketing. Look at the ads on TV that are so prominent. And I think I told you this when I did the child and adolescent course, but I have this habit for psychopharmacology or pharmacology in general. One is I always try to find out, or I always try to clarify what is the spelling on that medication. And I also, now that I have a smartphone, will pick up the smartphone and type in cost of this new medication, because I'm just curious about that and interested. And it's just amazing how expensive some of these newer medications that are being promoted on television, upwards of $50,000 a dosage for an injectable, a biological, a bioactive injectable, if you will, working with the immune system. All right. Other areas we're going to cover are the Drug Enforcement Administration schedules and categories, an important category. There will be some test questions on this. And to recognize off-label issues. You remember when I taught you that 80% of all mental health medications are prescribed off-label, not for the FDA indicated indication for them. And you have to, and you do this, it's legal, it's ethical to do, but you better document well and have your ducks in a row when you do this. To identify orders and prescription terms, I'm going to go through on a whiteboard tomorrow morning online symbols for you to take in and recognize for prescription writing, etc. And finally, to recognize the barriers to treatment for chemically dependent impaired professionals. All right. Slide number 6. We're going to start out today with ethical codes and standards. Let's get the framework, foundation for prescribing from our different professional societies that are involved in this. So that's I call it your APA and my APA. Yours is American Psychological Association, mine is American Psychiatric Association. Similar but different, of course. Accreditation agencies, Joint Commission, CARF, etc. HIPAA, or as our dear president said, HIPAA, in a recent press conference. It's pretty clear that he's never come across this before, at least for television. And government regulatory agencies such as the Food and Drug Administration, the Drug Enforcement Administration. We're going to talk about ethical dilemmas as they arise. We're going to get into an interesting section this afternoon, I believe, in the flow of things, of all the body of literature that is against prescribing psychopharmacologic agents to adults and children. And if you go on the internet and do something very generic like against psychopharmacology, you're going to come up with thousands of websites that will try to persuade you of the dangers and the lack of ethics and morality of prescribing mental health medications. Very important to understand, to follow, and to be able to address when you are confronted by a parent or a patient who says, this is going to kill me, or this is not safe, and this website told me so. And then we're going to, in this section too, talk about the pharmaceutical industry and their influence on prescribing. Next slide, we're going to get into the legal aspects of prescribing, medical malpractice. We're going to talk about a very important area, treating the treating therapist versus an expert witness in testimony in court. and legislative acts that specifically address this on a national and statewide basis. We'll start on this today, this afternoon, but more tomorrow. Will be on practice guidelines. We're going to go through a medical record page by page, documentation standards, also look at electronic medical records, EMRs, which since 2012 has been pushed heavily by Medicare. You hospitals and physicians and prescribers get higher reimbursement if they submit, if they work with, if they use electronic medical records than paper charting. So that's the push on that. I'm going to give you the latest and greatest on that. Advantages, disadvantages. We're going to actually write out some orders and do some prescription writing, even the Schedule 2, which is the most strict one with opiates, etc., and stimulants. We're going to go through all the decision trees and treatment guidelines, mostly in your references, and drug formularies. There's several drug formularies in your references. We're going to talk about managed care and their influence on treatment guidelines. We'll also look generally at resources related. Tomorrow, we're going to get into the whole important topic of patients' rights. When can you refuse a medication? What is informed consent? We went into this in some detail with the children and adolescents, but we're going to do it in a more overview way with adults this weekend. We're going to talk about patient education, special populations, intellectual disability folks. We will touch on children a little bit. We'll talk about different ethnic groups, different cultural groups, etc. And we're also going to talk about the right to refuse medication and what is involved in that, and the court citations that must be addressed related to the right to refuse medications. And we'll also talk about confidentiality. We will talk about quality outcomes. What is best practice? We're going to get into some detail on cultural issues. We will talk about interprofessional issues, who owns the patient, who's in charge, how to work well with other mental health disciplines, how to work poorly with them. And we're going to finish with the impaired professional. All right. Moving into the ethics codes itself, let's start out with the American Psychological Association. And it's in your references, the details on this. I'm just going to go through the highlights, if you will. All right. So, general principles. There are 5 of them. The most important one, the first one, is beneficence and non-malfeasance. What does beneficence and non-malfeasance mean? Well, beneficence is doing good, right? You're benefiting. Non-malfeasance is doing no harm. That's the Hippocratic Oath, do no harm. The second principle is fidelity and responsibility. So are you being faithful? Are you accurate? Are you consistent? Are your values there? Are you being responsible to the people you work with? Integrity. So integrity has to do with honesty and being true to one's values, right? Justice, fairness, reasonableness, equality. That's what the justice system is all about. The criminal justice system is, in theory, all about fairness and equality. And then finally, respect for people's rights and their dignity. All right. Folks, we're going to go for a few more minutes and then we'll take our first break. So let's just go over some of these terms just a little bit in detail. Non-malfeasance. It derives from the ancient maxim primum non nocere, which translated from the Latin means first, primum, do no harm, non nocere, do no harm, non-malfeasance. Now, in 2016, the American Psychological Association updated their ethics standards. And how did they update them? Well, it applies to specifically to complaints and to notices to show cause. It specified how investigations and unethical conduct would be divided out. Two types of investigations. One is to show cause proceedings. That would be an adverse action by another professional body. Say one state, you've had an action against you in that state, and that would be a show cause why the state that you're currently in would not take that into account and sanction you. And then also the other type of investigation is it reviews alleged unethical conduct initiated by either your PA or some complainant. All right. So part of the weekend's course is a series of questions. And we're going to take some questions, and none of these questions are graded. It's simply a learning experience. So Aiden, this is a time when we will go to the poll, if that's set up. And I'm going to leave it to you to switch from the PowerPoint to the poll and ask students to decide question 1. Beneficence and non-malfeasance refer to A, doing no harm, B, being trustworthy, C, being truthful, and D, being fair. Let's give
Doctor,
a moment.
I'm afraid for this one, they have to answer in the chat room.
Okay, all right. Okay, good enough. Everybody's got it. I pretty much handed it to you. These are lobs, right, to get us going on today. So non-malfeasance, doing no harm. Beneficence, doing good, right? Very good. Okay. Doing no harm. Excellent. Okay. Number 2, fidelity, responsibility. Is A, doing no harm, B, being trustworthy, C, being truthful, or D, being fair? What do you want to call it? Is fidelity and responsibility referring to, yep, you've got it. Okay, Jason, Robert. Okay, somebody answered C. And I may have confused you, I apologize. But being trustworthy is fidelity. Being responsible. Okay, very good. Again, kind of a lob to you. Integrity. What is the basis of integrity? Well, is it do no harm? Is it trustworthy? Is it truthful? Or is it fair? It's C. You guys have it down. It's being truthful. When you have integrity, you speak the truth. This is coming out, isn't it, right now in some of our leadership related to coronavirus. Can we trust our leaders? Do they have integrity? You be the judge. All right. And then finally, question 4, justice. What is the basis of this? It's D, exactly right. It's being fair. You have to have, if justice is to take place, there has to be an inherent fairness. There can't be an inside fix. It can't be biased. All right. There we go. So ladies and gentlemen, let's take our first break. It's 9:52 Pacific time. Let's start again at 2 minutes after the top of the hour. So that would be 10:02 Pacific time, 1:02 Eastern time. So we'll take a short 10-minute break right now. Okay, thank you. Can someone just acknowledge that they can hear me okay? Thank you. Very good. Okay, we'll get started again. We're on slide 21. The American Psychological Association 2016 edition of the Ethics Code. Section 1, resolving ethical issues. In your reference material, you don't need to look at it now, but it's all there. There's details on all of these issues. For example, if there are conflicts between ethics and the law, regulations, or other governing legal authority, it's your responsibility as a psychologist to clarify the nature of the conflict, to make known your commitment to the ethics code and take responsible steps to resolve the conflict consistent with these general principles. And under no circumstances may the standard be used to justify or defend violating human rights. With regard to the conflicts between ethics and organizational demands, perhaps you're working in a clinic or agency or facility that hands you organizational demands. You must, okay, related to psychopharmacology, you must endorse the use of stimulants for all kids. Otherwise, they won't be part of the clinic, that sort of stuff. It's your duty to try to resolve these ethical conflicts, to clarify the nature of the conflict, and to resolve it toward the benefit of the patient or client and not to violate human rights. The suggestion is to, and I've done this occasionally in my career, every couple of years, I will call my professional society, in my case, the local regional office of the American Psychiatric Association, talk with a psychiatrist who's well-versed in ethics and run by an ethical dilemma and get their opinion, a professional opinion, on how to resolve that dilemma. And I advise you to do likewise. The American Psychological Association and its regional branches and state branches have ethics committees to help advise you on resolving conflicts. All right, I'm not going to take too much more time on this slide. Slide number 22, second section, is on competence. The importance of knowing what you know and dealing with it, knowing what you don't know and either learning it or turfing it, delegating it, referring it, etc. It's incumbent on us as mental health professionals to know our boundaries of competence. There's a section on providing services in emergency situations. There's also details on maintaining your competence, continuing education, etc. Always learning, always being curious, always being willing to question what you've learned, question your authority, etc. And question the authority over you. Sections in the ethical guidelines in your references on the bases of scientific and professional judgments, delegating work to others, and how to deal with personal problems and conflicts with respect to ethical standards. All right. Section 3, human relations. Don't discriminate. Don't sexually harass. Don't harass in other ways. Avoid harm. Avoid multiple relationships, dual relationships, as much as humanly possible. In some rural areas, this is difficult, where you may be the only game in town and you run into the same people, including your clients and patients in the grocery store, at the soccer games, etc., and how to maintain proper boundaries. Conflicts of interest are important to understand and avoid. Third-party requests for services. Let me just give you a quick example of that. You may get, a prescriber might get a referral from a managed care company to evaluate a child for stimulant medication. Well, that's fine, but you want to do a thorough evaluation, and you want to have the independence and the ethics to be able to decide, is stimulant medication appropriate for this child? And you're not just going to sign off on it or agree to it because you've been asked to do that by the parent, by the school, by the teacher, by the pediatrician, etc. You want to avoid exploitive relationships, a quid pro quo. You do this for me, I'll do this for you, relationships. You want to cooperate with other professionals, be collegial, respectful. You want to get informed consent about what you're proposing, and we're going to go into that in some detail. And then there's psychological services delivered to or through organizations, and what to do if there's interruption in psychological services. All right. Section 4, maintaining or privacy and confidentiality, maintaining confidentiality, the limits of confidentiality. You know, pretty much everything is confidential unless it's reportable, homicidal, suicidal, etc. What you write in your notes, your recording, you're minimizing intrusions on privacy. You're not going to get into areas that are, quote, not your business, or don't pertain to the matter at hand from a therapeutic point of view or a clinical point of view. It reminds me of a case many years ago that a patient revealed to me that they may have murdered someone as a teenager. And this was a person in their 40s. And it was a beach party. It was craziness. It was lots of drugs and alcohol. And they may have been responsible. And I debated, and I even talked to my professional society, is this something I'm obligated to report of a possible murder? He wasn't sure if he was responsible or not, but he was so drugged up himself, etc. And it was decided not to report it. Disclosures, consultations with others, and the use of confidential information for didactic or other purposes. You will notice that any case I present to you will be redacted in terms of identity or identifying information. Very important when you're teaching. All right. Section 5, advertising other public statements about yourself. You have to be honest. Don't give guarantees. And in many parts of our field, there is a discouragement for advertising. Record keeping and fees. The importance of documentation. The importance of maintaining records. Whether or not you would withhold records if you were not paid. That's a controversial topic with no easy answer. What are the fee arrangements you've made? Do you insist on having the copay? Do you write off copays? These are all important areas to consider. Are you bartering? In some rural areas, bringing a load of grain or a couple of chickens may be the price for treatment. And what's that like? Is it fair? Is it reasonable? Can it be defended in court? And accuracy in reports to the payers. Always tell the truth, never lie, and then let the chips fall where they may. And do you get kickbacks? Are there fees? Do you get a bounty when you refer someone for treatment? This is all considered unethical, to get bounties or referral fees. All right, and then finally, the need to continue to educate ourselves and stay up with the latest and greatest in terms of training, and also stay up with research and publications to do your best in terms of getting to imparting good clinical information through case studies, rigorous studies, double-blind, placebo-controlled studies, etc. And we have an obligation to educate each other as professionals and to work hard to get good, solid information out there and prevent crappy information or biased information from being out there. And if we do find it out there, it's our responsibility to address it and challenge it. And then the ethical standards related to assessment, what is involved in that. final section is section 10, therapy itself and ethical standards. And we need to adhere to having true informed consent for therapy or psychotherapeutics. We need to be ethical in our therapy involving couples or families. We need to respect boundaries. We need to respect confidentiality. Group therapy, we need to be ethical in those standards. I've had an occasional case come across my desk of an individual patient who has had a terrible experience in group therapy with the group leader bad-mouthing, guilt-tripping, etc., group members in front of others, and violating boundaries in that regard. I've heard some pretty horror stories in that regard. How to provide therapy for others who are being served, or those being served by others, to not be in conflict with the other therapist, to collaborate with the other therapist. Do testimonials follow under section 10? Let me just double check that, Eddie. Yeah, I think so. Advertising and public statements, those would be, this is done all the time, Eddie, and I don't think it's bad. If you go on websites and you look at, say, residential treatment centers for adolescents, you'll often see testimonials by parents, etc., but they don't identify the kid and they don't give specific, identifying information. And I think that these can be ethically done. I think testimonials can be very helpful, but they have to be done in an ethical manner without identification. And it is section 5, right? Okay. So let's see, sexual intimacies with the current therapy clients, patients. It is the standard of the American Psychological Association not to have sexual intimacies with current or past patients. In the bad old days, I knew a number of psychiatrists who married their patients, and one in particular, I think he was on his 5th marriage with his 3rd or 4th patient, and I was very young, and I think I was in medical school at that time. I was back in Alabama, and was just kind of appalled by hearing about this. Thankfully, the ethics of both the American Psychological Association and American Psychiatric Association make strong points to prohibit this. Right. Okay. So Jason says, officially you have to wait a specific number of years after termination before you can enter into a sexual relationship. Yeah. I've always gone with the more strict thing of never, and there's no statute of limitation. But there are, there are people who advocate wait a year, wait 5 years, something like that. I mean, good luck with that, how to separate that out. All right. Ethics in interrupting therapy, ethics in terminating therapy. In my profession of psychiatry, if you are to terminate therapy, particularly if you're prescribing medication, the rule of thumb is to provide them access to a month's supply of medication and refer them to others. Now, sometimes the I've had one particular notable termination where I fired the patient and she demanded that she be given referrals for someone who would prescribe benzodiazepines for her. I wouldn't do that to any colleague, and because I didn't think it was appropriate. So what I did is I gave her, I said, I refer you to the local psychiatric society that has a referral list. And that's the best I could do. Right. So when studying for the EPPP, an instructor said it was changed from never as a means to better protect, changed, I thought it meant changed to never. Oh, I see, from never, right. Okay, yeah, to have a time, right, from never. So that you could, you know, if you were nailed in a court of law, you could say, I followed my professional society's guideline that I waited 3 years, or I waited 1 year, or I waited 5 years. All right. All right, now let's move on. And we'll move to the American Medical Association, the AMA. And this is revised in 2016 also. So less than 5 years ago. Very simple, it's on one slide. 9 categories, and it's extremely similar to the one for psychologists. First one is be competent. Know what you know and do it well, and know what you don't know and refer it out or get help. Know your boundaries. Know your areas of competence. Be honest in all things. In professional interactions. Even to the point of turning in colleagues who are dishonest. It's a very troublesome thing, but it is done. Respect for the law. Recognize responsibility to seek changes in those requirements which are contrary to the best interests of the patient. Number 4, respect for others, both patients and colleagues. So respect the rights of patients, the rights of colleagues, other health professionals. Safeguard patient confidences and privacies within the constraints of the law. 5, continuing education. Continue to study, apply, advance scientific knowledge. Maintain a commitment to medical education. Make relevant information available to patients, colleagues, and the public. Obtain consultation. Use the talents of other health professionals when indicated. Number 6, except in emergencies, you have the right to decide if you want to treat that patient or client. You have the right to decide whom you associate with, the environment in which you provide your care. You are not obligated beyond taking care of emergencies to take anyone on who you don't choose to. You have that freedom. Number 7, you have a requirement to participate in activities contributing to the improvement of the community, the betterment of public health. And 8, your responsibility is primarily to the patient, not to others, not to the funders, not to the facility, not to the state, etc. So think about this with regard to the old style, Soviet style of psychiatry where transgressors or political dissidents were sent off to psychiatric institutions for years, if not life. This violates fundamentally this premise number 8 of responsibility to the patient. And finally, we need to support access of medical care for all people, not discriminate. Now, take a look at these 2 slides, American Psychiatric Association, American Medical Association. They are exactly the same, the exact same slide. So, and by the way, even though this is so-called revised in 2016 for the AMA, it's actually straight out of the 2001 Code of Medical Ethics for the American Medical Association. There's an interesting phenomenon that the higher the so-called social status of the profession, the less detail there is about ethical principles. So in your references, for example, there's a fairly long article actually against the idea of mental health medications written in the Networker, a journal from California for marriage and family counselors, master's level therapists. Their code of ethics is many, many, many pages long, like 20 pages long. Don't do this, don't do that, don't do the other. Well, for physicians, it's simply 9 points. For psychologists, it's more than 9 points, but it's not 20 pages. So there is this sort of social professional hierarchy in front of you. So we've already covered it, the American Psychiatric Association, because we just covered it for the American Medical Association. Now, the child psychiatrists do it in a little bit more detail, but it is just 10 principles instead of 9. Now, because they add in the first principle of your job as a child psychiatrist is to promote optimum development of a child and adolescent. That fits in very nicely, if I do say so, with my course back in the fall on child and adolescent psychopharmacology that is totally focused on the use of pharmacotherapeutics with children and adolescents in order to have them have their optimum development, right? To either get them back on a normal developmental trajectory or get them to a normal development trajectory where they never have been. But that's the primary goal of the use of medications, is to stabilize the system, as you recall from my wording from 6 months ago, hopefully, to stabilize the system. That may be that child's brain with ADHD and frontal lobes. It may be the classroom setting, this family setting, the school setting, etc. To stabilize that kid in the group home, foster home, residential treatment, long-term care facility, or state hospital, in order to maximize their development, their normal development. All right. The other principles are similar, but worded a little bit different, such as promoting welfare and beneficence, to minimize harmful effects, to avoid malfeasance or bad treatment, bad outcomes. To be confidential in your workings, to get true informed consent Principle 4. Principle 6, to be aware of third-party influence, to be honest, fidelity, right? To be involved in scholarly and research activities, to advance your field, to advance the knowledge base, to confront quackery, to advocate and promote equity and justice for all children and adolescents, in this case, child and adolescent psychiatry. To professional rewards, what do I mean by that? To be aware of the role awards play in treatment judgments or actions. Internally motivated influences. Legal considerations. To be aware of the laws governing practice, particularly child abuse and neglect, custodial arrangements, threatening behaviors, assent and consent, release of information, documentation, treatment responsibilities, negligence. All right. And in your reference section, in your reference guide, is the whole detail of the Code of Ethics, a 20-page paper on those, 16-page paper on those details. You don't really need to go through that, but of course, if you have interest in learning more about it, I encourage you to do so. All right, question 5. Remember, none of these questions count for anything except just to keep us thinking and make sure we're on track with each other. Question 5. Professional ethical standards for physicians are more extensive and detailed than for clinical psychologists, and more extensive and detailed for clinical psychologists than for master's level mental health counselors. True or false? Correctite. It's false. Very good. Okay. You can see most of these questions are lobs. Shifting gears, we're heading now to the accreditation agencies. We've just covered the professional society ethics that pertain to psychopharmacology. That is the American Psychological Association, the American Psychiatric Association, the American Academy of Child and Adolescent Psychiatry, and the American Medical Association. Joint Commission has to do with accreditation of hospital organizations. It used to be called JCAHO, JCAHO, which was Joint Commission on Accreditation of Hospital Organizations. That's quite a mouthful, and it was changed in the last 10 years to Joint Commission. You should also just be aware of, although we're not going to go into it in any detail, the other main accreditation body for mental health facilities and substance use disorder facilities, treatment facilities, called CARF, C-A-R-F. And that's the Commission on Accreditation of Rehabilitation Facilities. It was started in 1966, and it is the accrediting body that the addiction treatment industry relies on, methadone clinics, residential treatment programs, etc. But they also rely on Joint Commission. So if you're sending a child, adolescent, or adult to an addiction treatment facility, ideally you want that facility to be both Joint Commission accredited and CARF accredited. That shows that they meet a standard that we're going to go into of credibility and honesty and integrity. that mimics the professional society standards for professionals. Joint Commission, founded in 1951, not-for-profit organization. It now accredits and evaluates over 22,000 healthcare organizations and programs, including walk-in clinics, ambulatory care centers, outpatient clinics, behavioral health organizations, health plans, home care organizations, hospitals, laboratories, long-term care facilities, long-term care pharmacies. Now, it does not cover prescribers' offices who may be prescribers. For example, it does not oversee the storage and dispensing of sample medication from a physician's private office. That is covered by the DEA, Drug Enforcement Administration. In my prescribing career, I had 2 visits, unannounced visits from the DEA to my office, my private office, my professional office. The DEA wanted to look at my sample cabinet. Was it properly locked inside a cupboard, inside a locked closet, so double lock, if you will. And it had an accounting with it of medications accepted and there in stock, and medications dispensed when, and an accounting of the number of pills. That's what DEA wanted. Joint Commission, not their business. They don't care. I mean, they do care, but it's not their business. It's not their purview. What are the guiding principles of the Joint Commission, the accreditation agency? And remember, the professional standards, ethical standards that we just covered in the last hour, it parallels these quite nicely, but in a different, nuanced way. So the guiding principles of Joint Commission is to improve patient safety, to reduce risk, to reduce errors by standardizing procedures. One of the biggest things that hospitals do as part of their Joint Commission projects is to look at, identify errors, mostly in prescribing or dispensing medications or procedures, and reduce those by standardizing. For example, if you go into a hospital these days, coronavirus aside, you are going to be asked 3 or 4 times your name, your date of birth, and they'll check it against that armband on your wrist because they don't want to dispense the wrong medication to you. They want to make sure you're the right patient. They want to check which arm they're operating on. So they're going to be checking, what are we doing today, madam or sir? You're going to do an operation on my right wrist, not your left wrist, but your right wrist, your right eye, not your left eye. So these redundancies are to reduce errors by standardizing procedures. And you might find yourself getting a little annoyed, or didn't I just answer that question about my date of birth? This is a way to standardize procedures and reduce errors, straight out of Joint Commission. It identifies the focus of accountability, how to prevent problems and where are they accountable to. Is it the nurse's station? Is it the MAR, the medication record, etc.? What is the focus of accountability? So there are whole divisions in hospitals and also treatment centers that job it is to embrace Joint Commission standards and to have an ongoing program of improving patient safety, reducing errors. There's a clear system of reporting errors and how they're dealt with. There's a follow-up. And we're going to see this in the medical record tomorrow when we go into this in detail of how to report these things. There's a so-called root cause analysis in response to a sentinel event. A sentinel event is an untoward event, a death, a near death, even a sentinel event is giving the wrong medication that could potentially harm the client or patient. Conducting proactive risk reduction activities. When I said about checking your armband and your date of birth and all like that, that's a proactive risk reduction activity, right? Moving on, slide 38. Always interested, Joint Commission is always interested in performance improvement. Identifying issues. It's kind of cool actually to be on one of these committees in the hospital or your treatment facility, because you're thinking outside the box. How can we improve things? How can we catch those errors and keep them from happening? We're always interested in improving. I was involved in a Joint Commission quality improvement project having to do with smoking cessation, where I was working with a population of adults, severely mentally ill, frequent diagnoses of paranoid schizophrenia, bipolar disorder, schizoaffective disorder, and many of these patients, for various reasons, were addicted to nicotine and cigarettes. They used the activating action of nicotine to counteract some of the deadening side effects, dulling side effects of antipsychotic medication. And it also gave them something to do, idle time. It was a social connection too, of smoke breaks and your buddies and all like that. And there was a culture around smoking. So as part of this quality improvement project, we started up a smoking cessation group. And in that, and we invited anyone who was interested, whether they were a smoker or a recent smoker or a current heavy smoker, moderate smoker. And we had a breathalyzer for carbon monoxide that we bought. We'd pass it around after cleaning it thoroughly with alcohol, swabs for your mouth, etc. And people would check their carbon monoxide levels. The heavy smokers learned that their carbon monoxide levels were quite a bit higher than if they had not smoked or if their smoking was reduced. And that was an objective way to help encourage them to cut down or quit smoking, shift to nicotine replacement, gum, patch, lozenge, etc. And the whole point was this quality improvement project to reduce smoking, and it worked. We talked about the ill effects of smoking, the costs of smoking, the effects, medical effects on your lungs, your heart, etc. And it was quite effective. We did a before and after with the study and we found that there was a reduction in our facility of smoking in general. So then we instituted it for all patients after that, and it was part of one of the ongoing groups. All right. Joint Commission also focuses on patients' rights. People need to be informed of the risks and the poor outcomes. It is out of Joint Commission that such things in patient medication education forms always list alternatives. If you don't take it, this is, here's an alternative way of dealing with, of not taking this medication, maybe more individual therapy, more group therapy, etc. More social manipulation, if you will, calming down the milieu. And here's what might happen if you don't take this medication when it's indicated. You might have more thought disorder, you might have more agitation, you might have more homicidal thoughts, etc. Joint Commission is also heavily involved in patient education altogether, and the use of medications and how to use them safely. All right. Guiding principles, continuing, is helping the consumer choose quality behavioral health care. So you, every program, hospital, treatment facility that is accredited by Joint Commission gets a little logo that they can, a little medallion, if you will, gold medallion, and they promote that, and that lets the public, the consumer, know that this is a facility that has passed these rigorous accreditation standards. Now let's talk for a moment about site visits and all like that. So before 2007, all site visits to hospitals or treatment facilities by Joint Commission was announced. You knew that in January of that year, you were going to have a site visit. Well, what do you think happened knowing ahead of time that they were coming? The hospital would literally spend 6 months before that site visit by Joint Commission buffing up their charts. They had whole committees of doctors and nurses and techs who poured through medical records sheet by sheet, and anything that was untoward, that was not compliant, they didn't have a proper signature, they didn't have a proper date or time for that note, was caught and corrected. And I remember an extremely awkward meeting that I was brought into early in my career after training, where I was asked to rewrite a note. In other words, tear out the old note from the medical record and rewrite it properly so that it would be, meet the Joint Commission standards. And everybody was sort of staring at me, and they knew it was not the right thing to ask me to do because it was unethical. It's unethical to destroy a note and rewrite a note, especially after the fact. Did I do it? I was young, I was green, I did what I was told. Everybody was embarrassed and awkward, etc. Well, by the time Joint Commission came around and did their visit, everybody sailed through, all the charts sailed through, everything was perfect, but it was artificial. It was done after the fact. So Joint Commission, in their wisdom in 2007, January 2007, started doing unannounced site visits. You knew that they would arrive on your doorstep sometime within the next year, and you had to have all your ducks in a row. They would literally arrive on Monday or Tuesday morning at 8:30 in the morning at the reception desk and say, we are the Joint Commission committee who is going to accredit you, and we want to see your records and talk to your staff. Well, you can believe that this caused a revolution with the hospitals and the treatment facilities. They had to have their ducks in a row all the time, 24/7. They had to have their charting done in a timely, real-time way. Any faulty medical records had to be addressed at the time. So they shifted everything immediately with much consternation to reviewing medical records like within 24 hours of notes being written. So there was now a whole ongoing committee, if you will, in medical records department that would review charts and call you over as a physician, as a prescriber, and bring you in to correct a record. And they wouldn't ask you to rewrite the note. They would ask you to correct it, put a line through it, initial, date it, and write the corrected information. Well, that was so much more honest and ethical, and it really changed how hospitals operated from this previous face-saving, kind of deceitful way, frankly, that really didn't reflect accurate patient care, to one that was more accurate. So, all right. Ladies and gentlemen, let's take a 10-minute break. It's 10 minutes before the hour. We'll finish up with a few non-graded questions on Joint Commission, and we'll shift to HIPAA. So I'll talk to you at 1 minute after the hour of 11 a.m. Pacific time. Ready, let's go ahead and get started again. This will be the final hour before we have our midday break for an hour. There are a couple of housekeeping things I wanted to mention that I meant to mention an hour ago, but I forgot. Aiden, the teaching assistant, and I talked this over. And remember, I told you that there's a final exam due within 2 weeks of the end of the course. Well, the other two requirements for the weekend course of the clinical vignette and a brief essay of less than 300 words, the deadline on that will be extended for the full 2 weeks. And also the reading of a review article and answering of 3 multiple choice questions. The deadline for completing that will also be extended for the 2 weeks. So everything will be extended for 2 weeks after the end of the course at the end of tomorrow, Sunday. This is to help you out, hopefully, regarding dealing with this pandemic crisis and everything else that you have on your plate, to give you a little bit more flexibility in completing these assignments. Okay. Someone will just give me the hi sign that they can hear me okay, and I'll continue on with the course material. Great, thank you. Eddie, hi, great. Okay, thanks, Brian. All right, all good, Mateo. Okay, now let's shift gears, and we're gonna have 2 lob questions related to Joint Commission. Question 6, a change in Joint Commission's review process of health facilities that significantly improved fidelity and integrity was the initiation of unannounced site visits in 2007. True or false? A, the answer is A. It definitely helped. Why Joint Commission that has started in 1951 and didn't do this for 56 years until 2007 kind of escapes me. We didn't think it was, we just fell into a tradition, and that's the way things happened, and that's the way it was. But it was bogus to buff your charts for months and months and months. It was dishonest. It did not follow the principles of Joint Commission. And so it is good that it's done with unannounced site visits. It sort of makes me think of the analogy of random urine tox screens. If you're having that as part of your treatment program as perhaps an impaired professional, or in a substance use disorder treatment program, these so-called random UDSs, or urine drug screens. Well, are they truly random? That's the question. Or do you know that every Monday morning you're going to have to produce a urine sample to verify that you're not using substances? And someone would simply not use, whatever offending substance, marijuana, it wouldn't work because that has such a long half-life and stays in your fat cells for up to a month. But for other drugs of abuse, you could get away with a clean urine tox screen because you knew that Monday morning was going to be the so-called random tox screen. Well, that's bogus. The way to do it with a true randomness is the way I've seen it done with impaired professionals, where they will, you'll get an email every morning saying, hello, Miss Smith or Dr. Jones. Today you need to report by 11 o'clock to your local Quest Labs, or whatever lab you have designated, to give a urine toxicology screen, to do a urine toxicology screen. Or, good morning, Miss Smith. Have a good day. We'll talk to you tomorrow. And it may be tomorrow. It may be the next day. It'll be sometime within the 7 days for the weekly random tox screen, but you don't know which day it's going to be. That is true randomness. So to Janelle's point, in the chat room, I worked in a psych hospital from 07 to 2010. These changes made all the difference in the world. Exactly right. And why didn't we think of it before? We were just burdened with this crappy system of these rigorous checks on your charts months after the fact, and then trying to persuade you to change your chart or rewrite it or something was just dishonest from start to finish. All right. Question 7. Joint Commission oversees procedures related to the storage and dispensing of sample medication from a physician's private office. I should say prescribers, and everybody's got it. It's false. Joint Commission deals with hospitals, treatment facilities, behavioral health organizations, outpatient clinics, etc., but not professionals' private offices. So if you are a prescribing psychologist in the state that allows you to do that, you will never be involved with Joint Commission if you have a sample cabinet. All right, so the answer is false. Okay, HIPAA, Health Insurance Portability and Accountability Act of 1996, that took effect in 2003. This was a major big deal at the time, and now we just it's old hat. We do it. It all pertains to access to one's medical records and privacy within those records and the use of personal information. So you now get a privacy notice by HIPAA. You go to a hospital, you go to a clinic, and you'll get a sheet that you acknowledge that you got this privacy notice. Its whole point is to promote best quality care for patients and clients. But, and this is critically important, it does not restrict the ability of treaters to share information needed to treat their patients. So if a patient or client ever said, by HIPAA guidelines, you're not allowed to talk to my other therapist or my prior therapist or my future therapist or my primary care doctor, that is not true. You are allowed to do that if there's good clinical reasons to do it. I may have mentioned the case of a patient of mine who was in her late 70s, who had been dependent on benzodiazepines for decades. And I worked my hardest to get her off them. And she would fire me at times and go find other prescribers. The latest one was a neurologist to prescribe the benzodiazepines. And I think it was Ativan. It may have been Xanax. I can't quite remember now. And she told me that she had been seeing this doctor. She refused to come see me. I had successfully weaned her off the benzodiazepine. She was no longer psychotic and super anxious. It had the paradoxical effect with her, the benzos. And it was now my job to contact the prescribing neurologist and say, doctor, you must not be aware of this, but she has been dependent on benzodiazepines for decades, and you've done a real disservice to her to get her back on them. It's going to have her become more anxious and psychotic, more dingy, and it's a therapeutic mistake. And when I called this doctor's office, his office manager did her very best to keep me from talking to the doctor, delaying me for weeks, saying the doctor doesn't want to talk to you. HIPAA guidelines won't allow him to. The patient expressly said that you don't have permission to talk to Dr. Brady, my prior psychiatrist. And I kept saying to her, you have to let me talk to the doctor. You have to. And she said, no, I won't. And I said, and finally, I just got fed up and I said, you put the doctor on the phone. If he doesn't get on the phone within 5 minutes, I'm going to report him to the State Medical Society for unethical behavior. HIPAA guidelines not only allow me, but suggest I talk to other treaters when it's clinically relevant. So he finally, reluctantly and angrily got on the phone with me. And what do you think he did? This is so typical. He fired the patient. He said, I don't want to have to deal with this. She lied to me. And how dare you, interrupt me? And I said, doctor, you have to wean her off the benzodiazepines. Here's how I suggest you do it. Well, he said, forget it. I'm just firing her. She's dishonest. And that's what he did. She went off the benzos abruptly. She became acutely psychotic and had to be hospitalized. Then we started over again. So HIPAA allowed me to do that, did not restrict the right of treaters to share information needed to treat their patients. HIPAA also has a prohibition on marketing, and this relates to pharmacies and health plans more than individual professionals. It provides for stronger, it provides a floor, a national floor, when state laws are not sufficient to protect patient privacy and medical records. So it provides that national floor. It has the treater taking reasonable steps, such as for confidentiality reasons. For example, calling a patient's work office and rather than their home, not saying, this is Dr. Smith, I'm treating your child, I'm treating your husband for depression, please have him call me. You're not allowed to do that with HIPAA. You have to do more circumscribed messages, and you have to talk with the patient beforehand. How do I get hold of you that maintains your privacy? What's the best way? Oh, leave a voicemail for me that you want me to call you back or something like that on this phone line. This perhaps it's your office line or your personal line. But the whole thing in terms of complaints, it's a pretty weak law. Civil penalty of $100 per incident. So even if you egregiously violated everything that we've just talked about, you would get nailed for a $100 civil penalty. All right. Let me just see if there's other things to say about this. This is something just out of interest, nothing you really have to remember, is the 2013 American Recovery and Reinvestment Act. And it included a so-called high-tech Health Information Technology for Economic and Clinical Health Act. And it provides Medicare and Medicaid money incentives for hospitals and prescribers to adopt electronic medical records. We talked about this before, 2013. So you get a higher monetary reimbursement if you're treating Medicare or Medicaid, in California, Medi-Cal patients using electronic health records, EMRs, EHRs, electronic health records, EMR, electronic medical records. And there was even a initiation phase that is now gone, where you could receive up to $44,000 per physician from Medicare if you to shift over to an electronic system. That's all. That was just a at the time, and a phase in. And it was done in conjunction with HIPAA. That's why I mention it in this part of the course. It was done as an add-on to HIPAA, that HIPAA privacy, security, enforcement rules were validated and incorporated into electronic medical records. And there's boxes in electronic medical records to talk about privacy, security, etc. Okay, this is kind of important. In HIPAA, what are excluded from health information is psychotherapy notes that are separate from the health record. So if you as a professional, mental health professional, maintain separate chart clinical notes, etc., for your clients or patients, separate from your health record, that is excluded from HIPAA. Okay, let's ask the lob question about HIPAA. The Health Insurance Portability and Accountability Act of 1996, HIPAA, restricts and prohibits a healthcare treater from sharing a patient's clinical information with another of the patient's healthcare treaters when therapeutically indicated. True or false? And the answer is false. You got it. You can do it. It doesn't endear you to the other treater who, like the neurologist who fired the patient. By the way, this happens unfortunately all the time, especially in chronic pain treatment and the overprescribing of opiates, where a prescriber of opiates will be challenged by another treater or state or other authorities for overprescribing for a particular patient. And most likely what the overprescribing prescriber does is fire the patient. That's how you get rid of the problem as quickly as possible. So Rebecca says, I don't think this is clear to PCPs and other providers. You're right, it's not. And it's our job. See, if you look at this superficially, it's about patient privacy. So you say, aha, HIPAA says that I can't reveal this information. Well, with my particular patient, the elderly woman, it was critical that I do so. I didn't want to. She had already fired me. I wasn't paid anything to do this. I didn't get anywhere with this. I knew that it would anger the doc and she would decompensate. And that's exactly what happened. And she had to be hospitalized. So you don't win any friends and influence people when you demand to talk to a a primary care doc and explain why you're calling and that it specifically does not violate HIPAA, they don't want to hear it. They want to fall back on privacy, which, by the way, I don't want to get too cynical here, but it's also a lazy way of operating, right? If you say, oh, the patient demands privacy and I can't share this with anybody, it saves you a phone call, it saves you investigations, it saves you all the hassle I went through over weeks with this neurologist when my patient fired me and went to another doc to get her benzos. You see how that works? It was very convenient for the neurologist to say, and the office manager to say, HIPAA guidelines don't allow this. So, and Eddie says, I've seen it preventing any and all information unless a specific time limited release of information is signed by the patient. And Eddie, I'm telling you that you don't need a release of information for sharing clinical information with another treater when it's therapeutically indicated. It's always a good idea therapeutically to do it. By the way, I had nothing to lose with my patient. She'd already fired me. And she would never, you can see what's going on here. She would never allow me to talk to anybody because she was deceptive and trying to doctor shop and find someone who would prescribe her benzos for her. So she would never sign a release of information. Yes, so it is something that should be told to the patient when discussing confidentiality. Absolutely. I operate, here's my phrase to them, I operate with your best interests in mind, sometimes even when that conflicts with what you think your best interests are. Specifically, if you are doctor shopping for medication, I am going to call that doctor and talk with them about this. And you have this conversation when you do have a rapport with the patient and they are trusting you. You don't do it after the fact because, you know, I mean, you could, but for the continuity of care, yeah, in the interest of continuity of care, you can see why my example with the benzodiazepine dependent elderly patient, it was therapeutically indicated and in the interest of continuity of care. So this is something I emphasize, and it's often distorted by both patients and providers who want to fall back on this issue of total privacy. Not if it's in their, if it's harmful to them. Remember, we have to do no harm. So that violates the Hippocratic Oath and the first point of our ethical guidelines. All right.
Doctor, is it okay if I run the attendance at this time?
Sure, go ahead, please. I don't know whether whether I should talk during this time or not. That's why I'm being silent.
It would be fine.
Okay. So Rebecca's point, thank you, Eddie. Rebecca's point is a good one. it comes into play with the elderly who have dementia, or you have to stop their driving because they're getting into accidents and they're not driving properly. You have a legal obligation in that regard to turn them in, but HIPAA also supports you in that. Somehow people got the notion way back when with HIPAA that it allowed them to hide nefarious things and deceitful things from other providers, and it does not. Specifically, it does not. So that's kind of the bottom line. All right. Let's go ahead and move on. And to the FDA, the Food and Drug Administration. FDA's in the press lately, right? Because of coronavirus, and trying to lighten up on regulations and get quick approvals for medications that may be helpful with coronavirus treatment. The whole sort of controversy around anti-malarial drugs, chloroquine and hydroquinone, and is being talked about. President Trump is an advocate of anything and everything, which good for him, but it should be scientifically based. It shouldn't just be anecdotal, and it should not be harmful. And there was that unfortunate case in Arizona recently of a husband and wife who used their anti-malarial medication that was to be used for fish tanks, to keep the fish tank clean from protozoa, and the husband died and the wife was put in the ICU because of taking massive doses. So FDA has to be in the crucible of this, where they have to be not so restrictive and so conservative that they never approve things until they have an overabundance of evidence. But they can't be too cavalier and quick about this. We'll talk about this later with thalidomide. Thalidomide, which was prescribed in the 1960s in Europe as a sleeping medication and caused short limbs, arms and legs, etc., in European countries, but only a few cases in the United States, because the FDA, being its conservative approving body, did not have the scientific research to back up the safety of this until it came to light that they weren't safe at all, and that a lot of European countries had jumped the gun on approving this. FDA was a savior and a saint in this for most Americans. But it can also backfire in slowness of approving safe therapies. So the FDA's mission is to promote and protect the public health by helping safe and effective products reach the market in a timely way, and monitoring these products for continued safety after they're in use. So it blends law and science. So good practice, good prescribing practice, and the best interests of the patient require that prescribers use legally available drugs, biologics, devices, according to their best knowledge and judgment. the prescribers have a responsibility to be well informed about the product, to base its use on firm scientific rationale, on sound medical evidence, and to maintain records of the use and effects. Okay. This is where we get into Institutional Review Board, which was a general term started in the 60s for certainly the FDA, but also hospitals approving medical procedures, surgical procedures, and medications for use in that hospital. And I mentioned to you when we talked about children and adolescents in the fall, Eddie's Lenz law. I don't know what Lenz law is, Eddie. Back in the fall, I talked about the off-label use of drugs, particularly for children and adolescents, because 80% of the meds that are prescribed are so-called off-label because they were never tested in children. So, for example, one of the more common medications prescribed for childhood attention deficit hyperactivity disorder is a blood pressure medication, Catapres or Clonidine, and it's off-label. It's an alpha agonist, knocks out your sympathetic nervous system, flight or fight, and thereby helps the ADHD diagnosed kid be less impulsive, activated, etc. All right? Okay. So here's a question for you. Off-label prescribing of psychopharmacologic medications is considered acceptable from an ethical and legal perspective, true or false? The answer is true. Whether you like it or not, it's true. Otherwise, 80% of the time we're being unethical or illegal? No. We have to be able to prescribe, prescribers have to be able to prescribe medications based on their scientific knowledge of the medication and the patient's condition. If we were relegated only to prescribing on-label medications, we would be terribly restricted. And remember the issue about thalidomide, it was never off-label or on-label. It was never allowed in the United States to be prescribed at all. So we're talking a different category for thalidomide and medications like it. These medications that are prescribed off-label are approved by the FDA for certain conditions, but they're approved. Thalidomide was never approved in the first place. All right. Moving on to the Drug Enforcement Administration, the DEA. All right. I want to find something to read you. And I've got to get it from the references. So give me a moment, please. There we go. It's page 2.1 of the references in the second section. I'm just going to briefly read to you their mission statement. The mission statement of the Drug Enforcement Administration is to enforce the Controlled Substances Regulations of the United States and bring to the criminal and civil justice system of the U.S. and other competent jurisdictions, those organizations and principal members of organizations involved in the growing, manufacture, and distribution of controlled substances in or destined for illicit use, and to recommend and support non-enforcement programs aimed at reducing illicit controlled substances in domestic and international markets. Okay, so and within the DEA there are different schedules, Schedule 1 through 5, Roman numeral 1 through 5, where this is all in your references. So just review that with you very quickly. Schedule 1, controlled substances. These are medications or substances that are not allowed to be prescribed at all. Roman numeral 1, Schedule 1. And the reason for that is that they have been deemed to have a high potential for abuse, and or the drug has no accepted medical use and treatment, and or there's a lack of accepted safety for the drug under medical supervision. So no prescriptions for Schedule 1 substances or drugs are allowed. So what are some of these drugs in Schedule 1? Well, marijuana is number 1. And isn't that weird? Marijuana is now legislatively permitted in a number of states in the United States. It is used for chronic pain. It's used for insomnia. It's used for anxiety and other conditions. And it is not. It's a Schedule 1 substance according to DEA. It's illegal to prescribe it. GHB, gamma hydroxybutyric acid, is not allowed. MDMA, ecstasy, is psilocybin, psychedelic mushrooms. These are all Schedule 1. Mescaline. Okay, these are all Schedule 1, not allowed to be prescribed, illegal. Now, let's go to Schedule 2. Schedule 2 are able to be prescribed. However, these drugs are deemed to have a high potential for abuse. They're currently accepted for medical use in the United States, but they may lead to severe psychological or physical dependence. Schedule 2, you need a triplicate, and we're going to go through this tomorrow when we talk about, Rebecca, should I be looking at this? Well, you're getting it from what I'm telling you, so that's good enough, but it is in section 2.3 of your references, and I think it is worthwhile to have a general sense of Schedule 1, Schedule 2, Schedule 3, Schedule 4, and Schedule 5, but I'm going to give it to you verbally right now. So, Schedule 2 medications, cocaine. So cocaine is, you would think, how could wouldn't cocaine be a Schedule 1 medication because it's a street drug? Well, Cocaine originally, way back when, you know, Coca-Cola days in the 1880s, etc., that's the coca, as in Coca-Cola, the coca leaf, etc. It is used as a topical anesthetic, and it is still used in the emergency room to stop nosebleeds that are intractable and won't stop on their own. It constricts your blood vessels, and you stop that massive nosebleed with cocaine. All right. Stimulant medication for ADHD is Schedule 2, right? It has a high abuse potential. So Ritalin, Concerta, in other words, methylphenidate, is Schedule 2. Opium, tincture of opium, laudanum, methadone, oxycodone. In other words, the opiates are in Schedule 2. High abuse potential, but legitimately prescribed for pain. Dilaudid, hydrocodone. How about the barbiturates? They're in Schedule 2. Secobarbital. Barbiturates are used for anti-seizure medication, and also for major tranquilizers. Okay, there's Schedule 2. Schedule 3. Schedule 3 is that have some potential for abuse, but not as much as Schedule 1 and 2. It's kind of subjective. If abuse of the drug may lead to moderate or low physical dependence or psychological dependence. So what are some examples of Schedule 3 medications that have less potential for abuse than the Schedule 2, the stimulants, the opiates, etc.? Anabolic steroids, intermediate acting barbiturates, rather than long-acting barbiturates. Ketamine, which is now being used, was experimental, is now being more accepted. Marinol, which is the synthetic form of THC, tetrahydrocannabinol. Paregoric, Camphor. These are Schedule 3 medications. Schedule 4 medications, Roman numeral 4. These are the majority of non-abusable or minimal low potential for abuse medications. The antibiotics, for example, are all Schedule 4. The benzodiazepines are thought to have a lower potential for abuse, so they're put in Schedule 4, where the opiates are in Schedule 2. So Restoril, temazepam is Schedule 4, Klonopin, alprazolam, Xanax. So ladies and gentlemen, I made a mistake. The short-acting barbiturates are in Schedule 2, secobarbital. And the long-acting barbiturates are in Schedule 4. The long-acting ones are phenobarbital. That's traditionally used for seizure control. Also in Schedule 4 is Provigil and Nuvigil, modafinil. Antidiarrheals or Lomotil is Schedule 4. And Schedule 5 are over-the-counter medications that have seemingly no or lowest potential for abuse or dependency. So that's how you break it down. So if you were asked a question, stimulant medications, what schedule, DEA schedule, that would be Schedule 2. If you're asked a question about benzodiazepines, what schedule, that would be Schedule 4. And if you were asked a question about cocaine, is it legally used? It is. Schedule 2 in emergency rooms for extreme nosebleeds. Now here's a question for you. Is it okay to prescribe medications that exceed recommendations by the FDA, specifically the PDR? Yes, it is permitted. You just have to document well why you're doing it. So I had the, let's go back to the FDA for a moment and thalidomide. And FDA's conservative ways back in the 60s of refusing to certify that thalidomide was safe. The studies just were not in, but the Europeans jumped the gun and approved it early. I had the honor and privilege of inviting a thalidomide victim, she would be very upset with me if I use that terminology, to a conference. Her name is Eileen Cronin, and she wrote a memoir called Mermaids. And she was born with her lower limbs not present, one above the knee and one below the knee. And she had to have, crutches and artificial limbs from the earliest of age. She traced it back to her mother and pregnancy, and it's not totally clear how this occurred, but her mother's OBGYN either gave it to her as a sample that he got from a drug representative, which is not okay. It wasn't even approved to have prescribing, much less samples, or possibly the mother got exposed to thalidomide when the parents flew from the United States to Germany. The father worked for Volkswagen in America as a dealer, a car dealer in Ohio, and went occasionally to conferences in Germany. And a well-meaning Scandinavian flight attendant gave this pregnant mother thalidomide to help her sleep on the long plane flight from the US to Europe. So it's not clear how Eileen got exposed to thalidomide, but the reality was that she did, and she's written about it beautifully and warmly with poignancy. And she would be an advocate for the FDA going slowly and carefully and conservatively approving new medications, right? All right. So we're going to throw some more lob questions at you before we take a lunch break. Marijuana is designated DEA schedule. A is 1, B is 2, C is 3, D is 4, E is 5. Answer A, 1. Yep, schedule 1. Everybody's got it. So this flies in the face of states and legislatures approving marijuana, and they've actually bypassed the whole medical system, if you will. It's not prescribed anymore. It's legal or it's not legal in that state. All right. Opioid medications are DEA schedule 1, 2, 3, 4, 5. The answer is 2 or B. High potential for abuse, right? But able to be prescribed, legitimate medical reasons to prescribe, but high danger. All right. Number 12, steroids, buprenorphine, which is the opiate replacement medication increasingly used as an alternative to methadone. What schedule are steroids and buprenorphine? Are they 1, 2, 3, or 4? The answer is C. See, these are lob questions. 3C, right? Okay. We're going to cover one last category before we take the lunch break, because it fits in nicely, and that is pregnancy categories. Now, prior to 2015, just 5 years ago, there were some clear-cut pregnancy categories. And now they're a little more vague, to be honest about it. In the old days, used since 1979 through 2015, we had letter-rated risk categories for pregnancy. In other words, did that medication cause genetic malformations or abnormalities? Did it cause damage to the pregnant mother's fetus? And it was very clear cut in the old days. Category A, B, C, D, or X. And what these specified, and I won't go into in detail anymore because frankly it's not relevant, but just to know for archival or historical reasons, that the higher the letter, the stronger the risk. So category A and B meant that there was known fetal abnormalities. There was fetal abnormalities in animals, but not in humans. That was category B. Or no fetal abnormalities. That would be D, the lightest weight one. Nowadays, since 2015, we have pregnancy FDA categories that are not numbered or lettered per se. Najib, I've lost your thought about, sorry, I thought the previous, it's B. I'm sorry, I lost that thought. We can go back to it if you want to. So nowadays, since 2016, or 2016 onward, after 2015, we have pregnancy risk, including labor and delivery, and we have lactation risk, including nursing mothers. We also have female and male reproductive potential. And each medication has wording on whether there is risk to the pregnancy, indications of risk in lactation or nursing mothers, and also risk for reproductive potential for males and females. So you don't have clean numbered categories like you had before, which is probably, well, it's not probably, it is definitely better, because these categories, A, B, C, D, and X, were kind of arbitrary, the cutoff. And now you have to say this medication is safe in pregnancy, safe in lactation, and safe in reproductive potential, or it's not. And so each medication is listed by dosing and potential risks to the fetus, to breastfeeding, and to reproduction. Why did the FDA make this change? Because many women were required to take medication during their pregnancy due to chronic conditions such as seizure disorder, epilepsy, diabetes, hypertension, high blood pressure, asthma, and to withhold the drug treatment would be dangerous for the mother and the baby. And it put women and doctors in a bind, because you were prescribing medication for them that was potentially at risk, and yet in the overall cost-benefit analysis, it was more beneficial to take the medication for these chronic medical conditions. So the FDA struggled and struggled with this, and they came up with the longer wording for each medication. Now, something I need to correct right now, maybe this is what Najib was referring to, is I made a mistake, folks, and I stand corrected, and I need to correct it for you right now. The prior to 2015 risk categories for pregnancy was the opposite scale, as I said. In other words, category A was no problem, and category D was major problem. And I said it the opposite way, and I apologize for that. So category A in the old language was well-controlled studies failed to demonstrate any risk to the fetus in the first trimester of pregnancy, and no risk in the later trimesters. Category D was positive evidence of fetal risk. And such examples that we would prescribe would be alprazolam, Xanax, or clonazepam, Klonopin, lorazepam, Ativan. So benzos have a risk for a pregnancy. And category X, in animals or humans, they have demonstrated fetal abnormalities. So thalidomide would be in that category of X, that it's prohibited altogether for pregnancy. So I apologize for that, but I hopefully have now corrected it. All right, so ladies and gentlemen, let's take an hour lunch break, or afternoon break for those in the East, and we will move on to ethical dilemmas within the mental health community, and we'll talk about evidence-based treatments, cosmetic psychopharmacology, placebos, medication development, and some of the articles and the references. So hope you have a good hour break, and we'll gather together again at 1 p.m. Pacific time, 4 p.m. Eastern time in just an hour from now. Okay, thanks.